I'm Denise Hodson-Zingman from the University of Iowa, and as Randy mentioned, this program's being recorded, and if you have any questions, put them in the chat. I'll be moderating, and we'll try to get to those questions either at the end of the presentation or if there's some natural pauses or if Dr. Rhodes asks for questions. This time I'd like to introduce Dr. Rhodes. Dr. Rhodes is a clinical associate professor of medicine here at the University of Iowa. He did his medical school and PhD at Eastern Virginia Medical School and Old Dominion University in Norfolk, Virginia, his residency at Vanderbilt, and then his cardiology fellowship at Vanderbilt and EP or electrophysiology training at Ohio State. He's been at the University of Iowa since 2016, where again, he's a clinical associate professor of medicine. He's an expert in the full range of electrophysiology, diagnostic, and therapeutic treatments. Today he's going to be presenting supraventricular tachycardia. Welcome, Dr. Rhodes. I'm going to turn the mic over to you now.
All right, thank you. All right, so today we're going to talk about supraventricular tachycardia, or SVT. In terms of what we hope to cover today is we're going to review mechanisms, clinical presentation, and evaluation of SVTs, management, and how the management can differ with some specific SVTs. Also going to talk about a little bit about some research that Steve Bale and I have been doing with mapping and ablation of AVRT that has made the procedure much more efficient, quicker, and hopefully safer. And then we're also going to discuss the management of asymptomatic preexcitation. No specific disclosures for this device, but I do serve on a business strategy advisory board for Boston Scientific. Much of my talk's going to come from the ACC/AHA Heart Rhythm Society guidelines for SVT. The last update that came out on SVT was in 2015, so we should be expecting another one in the an update in the next year or two. When we think about SVTs, there are multiple types of SVTs. The most common that we think about are the paroxysmal supraventricular tachycardias. Of those, there's three main types: AVRT, which tends to be the most common, AVRT, or a WPW-mediated tachycardia, and with that, is PJRT, which is a type of AVRT, and then atrial tachycardia. So that's the kind of the three most common, three of the PSVTs that we see. Now, within atrial tachycardia, it could be a focal atrial tachycardia, it may be a multifocal, and then rarely there's something called sinus node reentry, which is something we usually just see in the EP lab. Atrial flutter is also a type of SVT. Another SVT that can sometimes be more difficult to manage is just sinus tachycardia. This could be physiologic. At least in my clinic, we've been seeing more sinus tachycardia, it seems, in patients who they recovered from COVID, who just have a higher resting heart rate and a higher than expected exertional heart rate, as in some patients as they've recovered from COVID. Within that, there's also inappropriate sinus tachycardia, and then finally junctional tach. SVT has a prevalence of about 2.25 cases per 100 persons. We see in the US, we see about 89,000 new cases per year. That includes about 5,700 people who have PSVT. It's twice as common in women, and in those who are 65 or older, there's a 5-time risk of developing PSVT, and a lot of those tend to be more atrial tachs. Have an atrial tachycardia, they have risk factors for AFib. And in some of these, good percentage of these patients, it's almost like we're seeing their pulmonary vein atrial tachycardia. They just haven't, had clinical AFib yet. SVT by definition, is a tachycardia, so it should have a rate above 100 beats per minute. The mechanism for SVTs in general involves tissue from the His bundle or above. If we look at the PSVTs, like clinically, they tend to be more regular, have a rapid sudden onset termination. Like we talked about, the three PSVTs that we see are AVNRT, AVRT, and then atrial tachycardia. In terms of the EKGs, especially with the PSVTs, most of these patients have a structurally normal heart. So, their QRS is going to be narrow. They're having normal synchronous ventricular activation. In some patients, in this, in patients with more structural heart disease, who and our older patients, the SVT can give a wide complex tachycardia if they have a pre-existing bundle branch block or IVCD. We can see SVT with aberrancy. Most commonly, we'll see right bundle branch aberrancy with SVTs. If patient is pre-excited and they're having an SVT, it could be a wide complex tachycardia because they're actually conducting over the accessory pathway to give them a wide QRS. And in patients with a device, they could be having an SVT, but it looks like it's wide complex because the device is seeing that atrial event. It's then tracking the device appropriately in ventricular pacing. So they're in, for example, an atrial tachycardia, but they're paced very rapidly because the device is tracking that appropriately, and for every for the sensed event it sees, it's going to pace the ventricle. If we look at the mechanisms of the quote unquote regular SVTs, the most common, of course, is going to be AV nodal reentry, which involves basically two AV nodal pathways. We call it a fast and a slow. And so, with typical AV NRT, you're going, down the slow pathway, back up the fast. And with AVRT, we have an accessory pathway that's connecting the atria to the ventricle. And with AVRT, they could go what we call orthodromic, which is down the AV node and then back up the accessory pathway, which would give us a narrow QRS because you're going antegrade through the AV node. Or in the case of an antidromic, you'd have a Y complex tachycardia that's still regular, but you're going antegrade or down the accessory pathway and then back up the node. An atrial tachycardia, can give a regular SVT. Sometimes we will see a little bit of wobble at the onset, and then also sometimes with termination, we'll see, we'll call it a little bit of wobble as it kind of settles in before it really regularizes. And then flutter can also give, regular tachycardia. Atrial flutter, of course, is a macro reentrant tachycardia within the right atrium, but that can give you, a regular tachycardia. When we think of, the three mechanisms for an arrhythmia, the most common, that we see, with SVTs is reentry, in terms of you have two different pathways that are now looping together. With the atrial tachycardias, we can see enhanced automaticity. Triggered activity is more of these delayed after depolarizations that can occur. A lot of times they can lead to ectopy that can then trigger the SVT. If we look at reentry, what needs to happen with reentry is that you have two pathways with very different electrophysiological properties that are now forming a functional circuit. So what typically happens is you have one pathway that may conduct rapidly, but then recover slowly. The other pathway conducts slowly, but recovers quickly. And that allows you to get into a situation where, for example, in this case, where we have an accessory pathway, when they're in sinus rhythm, we're getting fusion between the AV node and the accessory pathway. And most commonly, the AV node is typically slower than the accessory pathway. So this gives us that delta wave under EKG. So we're engaging both pathways at the same time. They're conducting at different speeds, but as the accessory pathway can be faster than the AV node, that gives us the fusion or the delta wave because we're seeing that accessory pathway since it's quicker. Now, what happens, in terms of what sets up a reentrant circuit is it typically takes, basically an early beat, in this case, a PAC. The PAC comes in early. The accessory pathway is refractory, so it's not able to conduct down the accessory pathway. So we have block in one of the limbs. Now the AV node is ready, and we have that conduction going down the AV node. And the time it takes to conduct down the AV node, the accessory pathway is now recovered. And now we'll end up going retrograde through the accessory pathway, back through the atrium, back to the AV node. and the time it took to get retrograde through the accessory pathway, the AV nodes recovery, and then that sets up your reentrant circuit. So so the fundamentals of reentry are two pathways. They typically can have different electrophysiological properties, and typically one conducts faster than the other, and then their recovery times are different, and that's what sets up or allows this functional circuit to occur. When patients present with SVT, most commonly they're going to have palpitations. Now, with these palpitations, they may experience chest pain, dyspnea, they may have lightheadedness, they may also feel, have anxiety. With sustained episodes of SVT, patients will complain of polyuria. That is due to the release of atrial and natriuretic peptide, because you're getting an increased atrial pressure from contraction of the atria against a closed valve. So that stretch leads to the leads to the release of AMP to diurese the patient, to decrease the volume on the atria, and that will lead to polyuria. Some patients can have syncope about 15%, and that could be due to how quickly the SVT conducts. And a lot of these patients are younger. They have they may be a young woman who has low borderline blood pressure. On a good day, they're running 100 to 110 systolic. They go into an SVT at 190. They're certainly going to have some hypotension that could lead, unfortunately, to syncope. Or in older adults, they may be tachycardia, where they have their SVT. When the SVT terminates, they have a sinus pause, and then that leads to syncope. When we take a history in someone who we suspect has an SVT, the things that we're going to key on is the number of episodes, how long do they last, how what's the frequency, what's the mode of onset, are there any triggers, what are the symptoms. A lot of times I'll really get into if I think this is more of a reentrant SVT, in terms of, I think it's AVRT or AVRT, did these episodes happen when when the person was much younger, and it happened through school age, through high school, they start having more in college, or if it's an older adult, did these episodes just start happening more frequently. 65-year-old hypertensive diabetic with sleep apnea, I'm thinking more atrial tachycardia, possibly flutter, AFib, just based on the their clinical factors and their age of presentation. Does the tachycardia feel regular? Does it feel irregular? Have they ever checked their pulse? And then once again, what's the age of onset? The physical exam, if you're examining a patient in SVT, you may see prominent jugular A waves, and once again, that's due to the atria contracting, against a closed tricuspid valve. Since a lot of the PSVT patients are younger, they have a structurally normal heart. Once they're in sinus rhythm, physical exam is going to be normal. We're going to look at EKGs at baseline. ECGs are ambulatory monitors, Holters, event monitors that hopefully have captured the tachycardia, to look at, the onset, the termination. Is it regular? Is it wide? Are there any electrolyte abnormalities that could possibly trigger the episodes? What's their thyroid status? And then, in patients, we're going to get basically an echo to rule out any structural heart disease. So, ECGs, if someone's in SVT, we're going to look at the ECG in the tachycardia. We're going to look for P waves, or, you get 5 EPs in a room, you're going to have, could have a fist fight about what's a P wave, what's a Ditzel, what's the backside of QRS, but we'll look for P waves. Ideally, if we can have the patient hooked up, if we're going to give them adenosine, a lot of times we'll call the EKG lab, have them hooked up. We'll run paper, when we terminate, just to look at the termination much closely. Once, if it's a patient who's never had an EKG, but their presenting EKG is in some type of SVT, we'll get another ECG in sinus rhythm, obviously to look for any evidence of preexcitation at baseline, but also, like we teach the fellows, we're going to look at the EKG in tachycardia. We're going to look at the EKG in sinus rhythm to see if any subtle changes in the QRS could be due to a retrograde P wave in the to see any differences between the tachycardia and sinus rhythm. So if we look at this flow chart is from the 2015 SVT guidelines. It really helps us basically diagnose a narrow complex SVT. So the first thing we're going to look at is the tachycardia regular. If it isn't, then we're thinking atrial tachycardia. Are we thinking flutter with variable block? Are there multiple different P wave morphologies? So we're thinking, multifocal atrial tachycardia. If it's just not regular. If it is regular, then once again we're going to scan the ECG to look for P waves. Are there P waves? Is the QRS changed in tachycardia versus in sinus, when they're in normal sinus rhythm? Do we see clear P waves? If we don't see clear P waves, then we're automatically leaning towards avrt, because the suspicion is that those P waves are actually within the QRS. So they're not, basically we're not seeing those P waves because they're within the QRS. If we see P waves, we're going to look at, basically we're going to march them out, look at the atrial rate to see if, in some cases, the atrial rate is faster than the ventricular rate. If it is, then you're thinking atrial tachycardia versus an atrial flutter. Now, if the atrial rate is not greater than ventricular rate, or they're 1-to-1, we're then going to look at the EKG to say, is this a short RP or is it a long RP SVT? So, and what that measurement really comes down to is if we're looking at, if the RP time is less than 90 milliseconds, we're most likely dealing with typical AV and RT. If it's, greater than 90 milliseconds, we're looking at, AVRT, atypical AVRT, or it could be atrial tachycardia. If it's a long RP, we're thinking atrial tachycardia, atypical AV and RT, or, in some rare cases, PJRT. So when we look at that EKG, what we're going to do is we're going to, identify what we think is the P wave, and then we're going to measure from the R wave to the onset of the P wave, and then we're going to look at the R to R interval. So if it's, more than 50% of the RR interval, we're going to call it a long RP. If it's if it's much shorter than that, then it's a short RP SVT. And within the short RP SVTs, it's typical AV and RT would be the most common. AVRT can also be a short RP, as well as atrial tach. If it's a long RP, we're looking at, thinking more atypical AV and RT. Atrial tach is still a consideration. And then, some AVRTs can give you a long RP, and most commonly within a long RP, that's this long, it could be PGRT. So in terms of the acute treatment of a regular SVT, so you've got a patient, they're in a regular SVT, the first maneuvers that we're going to try would be either a vagal maneuver or IV adenosine. Okay. If this isn't effective or not feasible in terms of the Valsalva didn't work, you're seeing a patient in clinic, you don't have IV access, the Valsalva doesn't work, you don't have IV access, you don't have ready availability of adenosine. The next question is are they hemodynamically stable? So if they are stable, then hopefully we're going to obtain IV access, and we're looking at options of IV beta blockers, IV diltiazem, or IV verapamil. Most commonly, we're going to most likely use IV beta blocker, IV DILT. Some of these patients, when they're in a regular SVT, there's going to be some blood pressure effect. Verapamil, can have a significant effect on blood pressure. So I think, most commonly, we're going to use an IV beta blocker or IV DILT, and less commonly probably IV verapamil, just given the blood pressure concerns. If they're not hemodynamically stable, then the next step is just a synchronized cardioversion. In patients who remain in SVT despite for example, a vagal maneuver, despite adenosine, despite IV beta blocker, IV diltiazem, then kind of your next step can be a cardioversion. When it comes to the Valsalva maneuvers, unfortunately, these have a success rate of about 5 to 20%. In Lancet in 2015, they published the Revert Trial, which looked at a modified Valsalva maneuver that was tested in emergency departments in England. And what the and with the Revert trial, what they did was it was a randomized controlled, had a parallel group trial, and it was like done in emergency departments in England. What they did was the standard kind of recumbent Valsalva versus the modified Valsalva. So this was semi-recumbent. Once they had done their strain phase, they were then placed supine, and then they then had a passive leg raise. So during the strain phase, they were trying to get people to strain for about 40 millimeters of mercury for 15 seconds. So the easiest way to do that is you give a patient a 10 cc syringe with the plunger in place. If they're able to blow against a blow, through that syringe and move the plunger, that's about 40 millimeters of mercury. So that's all you kind of need. So basically just a new syringe, you have them, basically blow, and try to move the plunger for about 15 seconds. Now, at the end of that, what you're going to do is they're initially sitting up during that strain phase. You're then going to, quickly lay them supine. You're going to raise the legs. What that will do, it's going to basically increase venous return. It's going to hasten that vagal response, and the vagus nerve, with its innervation to the AV node, will slow conduction through the AV node, increase the AV node refractory period, and hopefully terminate the tachycardia. So the primary outcome was a return to sinus rhythm within 1 minute of either a standard Valsalva or this modified Valsalva. So they looked at 433 patients. The standard Valsalva had a 17% success rate with the standard Valsalva. With the modified Valsalva, they had a 43% success rate. So marked improvement, and really one of the very cost-effective treatment. It increased the success rate almost threefold. And it basically eliminated the need for adenosine, and the only cost was the 10 cc syringe for them to blow through, and there was no adverse events. With adenosine, for patients who remain in SVT despite a Valsalva maneuver, typically we're going to recommend 6 milligram rapid IV bolus. The one thing that we see commonly was they give the adenosine, then they can't find the flush, and so you're not really getting an effective adenosine dose. So what we have the fellows do and the nurses do is we'll put on a T syringe connector. I have the adenosine in one syringe. I have my flush syringe on the other port. Quickly push in the adenosine, and then basically flip the basically flip the stopcock, and then rapidly push in your bolus to get it in. So if there's no result within 1 to 2 minutes, you can then increase to 12 milligrams. You can repeat 12 milligram dose one time. You can safely use up to 18 milligrams if needed, but most likely, a lot of times when we don't see an adenosine effect, it's just because there was a delay in kind of giving it rapidly in that bolus. Now, one thing to caution is we do see SVTs in patients who have had cardiac transplant. A lot of times these patients are receiving younger hearts. Not uncommonly, we'll see AVRT, AVRT, in these patients, post-transplant. Because the heart's denervated, we use adenosine, very cautiously and at a much lower dose, because it can lead to profound, asystole, with traditional doses. So, if I have a patient who, has a transplant, has SVT, I need to give adenosine. I'm going to basically start low. Like I typically start at 1 milligram. If that doesn't have effect, I may go to 2. I've never had to go above a 2, thus far. Unfortunately, sometimes the fellows will forget this. And when I was at another institution, the fellow didn't appreciate that, gave, 6 milligrams of adenosine, terminated the SVT, had prolonged asystole, and to quote the fellow, it was the longest 30 seconds of his life. So, but with a denervated heart, just start very cautiously, typically at 1 milligram, and then go from there. Now, adenosine, it does, has a much higher termination rate, anywhere from about 80 to 96%. Most of the time, and that's with giving it rapidly, giving it correctly, giving it with a flush right afterwards. Unfortunately, adenosine's very uncomfortable. Patients know when they've gotten adenosine, they basically say there's chest discomfort. It feels like their heart stopping, which it truly is. They're very, dyspneic. They're very flushed. Serious adverse effects are rare, just because it has such a short half-life. Now, adenosine can be both therapeutic and diagnostic. So the hope is that you're going to terminate the SVT, but in some cases, it at least can reveal the mechanism. So if an SVT terminates with adenosine, it really doesn't help you diagnose the SVT. It's great that they're out of it, but it really doesn't directly diagnose the type of SVT. If you look at the termination, if it terminates with a P wave, so you basically have a P wave after that last QRS, that favors avrt or AVNRT. If you terminate with a QRS, it favors atrial tach. Now, in some cases, you may have continuation of your SVT, but with the adenosine, you have AV block, and that may reveal, in this case, there's suspicion for flutter before, but with the adenosine, we clearly have flutter waves, or in some cases you may, terminate, you may have AV block with the adenosine infusion, and now you see your P waves kind of marching through. So adenosine can be both, therapeutic and diagnostic. If we look at once again, we looked at this, the acute treatment for regular SVTs, you're going to try your, vagal maneuvers. If those don't work, and I've just gone to the modified with the, with the strength, it's just more effective. Then if that doesn't work, you're going to try, IV adenosine. Then the question is, are they hemodynamically stable? If they're hemodynamically stable, you have time. You can put them on. You give them IV beta blocker, IV ties them. If they're not stable, then you're looking at cardioversion. So, this was a 51-year-old woman. She presented with palpitations and chest tightness. So clearly, a regular narrow complex tachycardia. We don't. If we scan for P waves, there may be something here on the backside of the QRS. There may be an R prime in V1 that could be a P wave. The other thing that we'll notice with her is that she does have some fairly impressive ST depression that is most likely rate related, just because she's clipping along. So she was given Valsalva's did not terminate her tachycardia. She was given adenosine, and then she, this is her post, this is her ECG and sinus rhythm. So normal, normal intervals, no evidence of preexcitation. Thankfully, her, STs have improved drastically, not completely, not back to completely normal, but improved drastically to a termination of her tachycardia. Now, one thing that we'll look at is, that Ditzel, what we thought was a P wave on the backside, just on the backside of the QRS, isn't there in sinus rhythm. Also, what we saw before, what we're thinking was, an R prime in V1, it's also not there in sinus rhythm. So very suspicious and consistent with that was the retrograde P wave. So if we look at, it's basically the pseudo R sign in V1 in patients with typical AVNRT. So, in tachycardia, we have this R prime, which is actually the retrograde P wave. When they're in sinus rhythm, we don't see it. Okay. So in this case, what we're seeing is, this patient was in, typical AVNRT. So when we look at AVNRT, there's two types. The most common that we see is typical AVNRT or slow fast. So they go down, antegrade down the slow pathway, retrograde up the fast. And so this leads to a short RP with a pseudo R prime in V1. Now with atypical AVNRT, this is the reverse of that. So they're antegrade fast, retrograde slow, and this leads to a long RP. So this was a case I did at Ohio State, that was done at Ohio State, that, this is intracardiac. So with intracardiacs during an EP study, we typically have 3 ECG leads. In this case, we have lead 1, lead 2, and then a precordial lead V1. This was a 3 catheter study. So we had a catheter in the high right, we had a catheter at the AV node recording a hiss, and then we had an RV catheter. So as we're watching this along, they're in sinus rhythm. So we're basically going, sinus rhythm, and then another sinus beat. Okay. And then they spontaneously had this PAC. So this PAC comes in, the AV node is refractory. So the fast pathway of the AV node is refractory, but the slow pathway is available. So this early PAC conducts antegrade down the slow pathway. Now in the time that it's conducted slowly down the slow pathway, the fast pathway has recovered and it can go retrograde. So then we go back to this A, okay? And then,
hey, Troy, if I could interrupt, I don't think that the viewers can see your cursor pointing things out. So you might have to be a little bit more. Oh, there we go.
okay.
Yeah, maybe it's just moving quickly. Okay.
Okay. So,
or it disappears.
okay. So in this case, we have an early PAC. It comes in, it comes in early. It comes in earlier. The AV node, the fast path of the AV node is refractory. So we go down the slow pathway, and then the time that we conducted down the slow pathway, the fast pathway is recovered, and so we go retrograde up the fast. In that time, the slow pathway, even though it conducts slowly, it recovers quickly. So we go down the slow and up the fast. Okay, so this is the induction of typical AVNRT. And what we'll notice, speaking to that, that R prime and V1. So here's our sinus beats. We don't have that R prime. Okay, here's that PAC, but with the onset of tachycardia, then we have that R prime and V1. Okay, and that's basically what we see on the surface ECG, and then also what we see on the intracardiacs. So, what we see in patients with AVNRT is they have 2 pathways through their AV node. They have the fast and the slow. Now, and that's been known. What Steve Bailey and I have done recently, we've actually done some high density mapping in sinus rhythm with one of the mapping systems that gives us very high, basically high density data in sinus rhythm in tachycardia, so we can actually look at the conduction between the fast and the slow. So, what typically happens is, we have a fast pathway, and then we have have this slow pathway. When they're in sinus rhythm, all the conduction is through the fast pathway. We really don't see the slow pathway until we have a PAC or an early beat that catches the 2 pathways kind of off timing. So what we see, so this is basically the right atrium. We have a catheter kind of like the low right atrium. This is kind of where the AV node is. This is a CS catheter, so this is the start of the CS going out. The tricuspid valve is sitting right here, and all we've done is we basically have looked at conduction through the AV through the AV node in sinus rhythm. And one of the things that we were actually able to see with the mapping system is we're actually able to see both fast and slow pathway in sinus rhythm. Okay, so that was kind of one of the things that we're actually able to see. And then what we noticed is there's actually conduction through both pathways antegrade. But what happens is there's a functional line of block that kind of separates the fast from the slow. So we're actually seeing, kind of fusion between, the fast and the slow. And we're actually able to kind of see that with the mapping system. So what happened is so this is just basically, the colors are activation timing. Red is early, and as we get into the blues and purple, they're later. So what's happening is we're seeing fast pathway here, through the fast pathway, and then we're also seeing the emergence of the slow pathway and where the slow pathway would break out. Now, classically, when we were all trained to ablate the slow pathway, we would look for these very fractionated signals that had, basically had a, very, what we call a, very highly fractionated, a kind of a fuzzy A, with a large V. And we basically what we're looking for is basically fusion between the fast and the slow pathway. And that led to this double component with the fractionation. And so we're actually able to see that with the mapping system in sinus rhythm, and we're also actually to see where the slow pathway kind of emerges in sinus rhythm. So initially we started doing this just with this, it's called the Orion. It's a mapping, it's a basket. It basically it's on a balloon, and we can adjust the size of it. It has electrodes that surround it, and so we can basically park it in a position, collect all the activation, at that point, move it, collect more data. And so we're basically just building, activation throughout time. But we also realize is we can also do it just with the ablation catheter and get enough density to actually see where the slow pathway emerges. So, what we would see in sinus rhythm is, so we see, the fast pathway come through, and then we see the slow pathway break out down here, and that's where kind of the slow pathway is exiting. So we're actually seeing, antegrade conduction through both the fast and the slow, in sinus rhythm. So if we look at kind of the color map for that, so what we also started doing is we would, try to induce AVNRT, and when we try to induce AVNRT, we would induce, basically, cause earlier and earlier PACs that we would basically try to find an interval where that PAC would come in. It would block in the fast pathway. When the fast pathway was refractory, it would then, basically exclusively conduct through the slow, and we could actually see where the slow pathway emerged. And so we're basically able to confirm the exit site of the slow pathway in sinus rhythm by fusion between the fast and the slow in sinus rhythm. And we can also do it as we induced AVNRT. And so what we would do is, we would program in an earlier PAC. So kind of there's a lot on this screen, but this is kind of that same map. Here's the EGMs at the time. So we're pacing at 100 beats per minute, and then we bring in an earlier PAC. So when this PAC comes in, the fast pathway is refractory. And so we conduct only down the slow pathway, and then that induces AVNRT, and then we go backwards through the fast pathway. But what we were seeing was, basically the site at which the slow pathway emerged when we had exclusive slow pathway conduction. So we were able to basically confirm where the slow pathway emerged in sinus rhythm, and if we and also at the same exact site when we initiated AVNRT and only had slow pathway conduction because the fast pathway was blocked. What that actually, we were able to do was, much quickly identify the successful ablation site to show right exactly where the slow pathway emerged. We could overlay the maps in sinus rhythm or with the initiation of tachycardia, and it got to the point where we would induce the tachycardia, confirm the tachycardia, do our entrainment maneuvers, and then we would just quickly map in sinus rhythm, looking for, basically where the slow pathway exited, identify that site, and, and then ablate at that site. Typically the site is, is well below our lowest His potentials. It's a safe site to ablate. And, in most of these cases, once we identified where that slow pathway exited, 1 or 2 lesions, and we had no slow pathway conduction, fast pathway typically gets better as you remove the kind of the vagal inputs between the slow and the fast. So we're actually really pleased that the sinus maps and the tachycardia maps, basically identified where the slow pathway was, very easily. So it's made, a quicker procedure, a safer procedure, and then, we're basically, in most cases, patients aren't having residual slow pathway conduction. So kind of we're going to shift gears to AVRT. This is more WPW, where you have an extranodal pathway that's connecting the atrium and the ventricle. We classify these by location, the type of conduction. Are they decremental? Are they non-decremental? also what direction they conduct. Do they conduct in antegrade? Do they conduct retrograde? Do they conduct in both degrees? In some case, if they're retrograde only, they're what we call concealed, because we don't know they have an accessory pathway because they have no evidence on their baseline ECG, but we see it during EP study. AVRT can go orthodromic, which means going down the node first, giving you a narrow QRS, or if they go down the accessory pathway first or antegrade, that gives you a wide QRS. So in patients who, there are patients who undergo EKG screening for, because they have a high-risk occupation, such as a fireman, police officer, a pilot, but those patients really haven't had symptoms, but they have pre-excitation. We'd say they have pre-excitation pattern. In patients with pre-excitation that you either have a documented SVT or symptoms, palpitations, episodic dyspnea, lightheadedness, or syncope that could be consistent with an SVT, they have true WPW. So this was a patient who presented with a narrow complex tachycardia. There's clearly some baseline artifact. It's really hard to identify any clear P waves. They didn't terminate with Valsalva maneuver 6 milligrams of adenosine. They finally got 12. They terminated. It's not uncommon to have some have some NSVT with termination. Is just since they've been going so rapidly. But what we see is, while the AV node's blocked, we then reveal their pre-excitation. So the AV node's blocked, the accessory pathway wasn't affected, and then that brings out their pre-excitation. What can be seen in patients, and some, if we see this not uncommonly, where they're presenting EKG is pre-excited AFib. And so what we see with pre-excited AFib is, basically it's an irregular tachycardia. It has variable degree. The QRS width is very variable, and that's due to, basically just different degrees of conduction between the AV node and the accessory pathway. As they conduct more rapidly, they get much wider because the AV node blocks. The accessory pathway is able to conduct. What we see on this EKG is, they have very irregular, very wide. The width of the QRS is very variable, but also on this beats, they go narrow because the accessory pathway blocked, and then they went through the AV node. So if this patient is hemodynamically unstable, the next step would be cardioversion. If they're hemodynamically stable, your drug options would be IV procainamide or IV ibutilide. So for patients who present with orthodromic AVRT, we're going to look for, do they have pre-excitation on their resting EKG? And really, if they have AVRT, we've confirmed AVRT, they're pre-excited, the next step is really ablation. I mean, that's really the curative approach for these patients. Medications options are really for patients who are hesitant to ablation, but this is something that we can cure, very effectively with a 3-hour, outpatient procedure. So the medical management of WPW should be fairly limited. This is a patient who had a left posterior septal accessory pathway. So once again, I've built, like, this is kind of a picture of the left atrium, and here's our coronary sinus catheter. This is the fluoro version of that. So we have we're kind of looking down, looking at the heart from the apex. So here's our CS catheter going out around the mitral valve. We have a catheter in the RV, and then in this case, since it was a left-sided accessory pathway, I have a sheath across the septum and into the left atrium, and then curve back to the left posterior septum. So, what I was doing at the time was I was pacing from the coronary sinus, which is, closer to that accessory pathway, to really get maximal pre-excitation. And then what we did is we just, with the mapping catheter, mapped to look for the earliest V. So we're maximally pre-excited, and then we put the mapping catheter where, in the region that we think the accessory pathway is. And then what we see is we basically see this track, of the accessory pathway, and then as it breaks into the ventricle, it kind of spreads out. But that's where the accessory pathway course is. And then ablation lesions at that site, this bead is pre-excited. As we're ablating, we lose pre-excitation and we go to a narrow QRS. So once again, patients who have AVRT, have pre-excitation, ablation is a class 1 indication. It's a curative option for these patients. So medical management is really should be a limited option these days. In patients who have asymptomatic pre-excitation, they've had no tachycardia symptoms, no palpitations, no lightheadedness, they've never passed out. One thing that can help is if these patients have abrupt loss of pre-excitation, either on during an exercise stress test or on an ambulatory monitor. If they have loss of pre-excitation, that really identify patients who have a lower risk, because if their accessory pathway can't keep up beyond 100 beats per minute, they're very low risk for having any type of event, just because it's a weak pathway. In patients who maintain their pre-excitation but are asymptomatic, it's reasonable to risk stratify those patients for rhythmic events. Catheter ablation of accessory pathway is reasonable in asymptomatic patients with a high risk accessory pathway. For example, we'll try to induce AFib to look at the shortest R-to-R interval to see how quickly that accessory pathway can conduct. But it's a 2A, even if they're asymptomatic but have a high risk pathway for ablation. There are some patients who this was identified through some type of warrant screening, where they have a high risk occupation as a police officer, they're a fireman or a pilot. They've been asymptomatic, but they can't pursue that employment because of their pre-excitation. It's very reasonable to proceed. It's reasonable to proceed with ablation at that point. And in other patients, you can also observe. We're going to kind of shift gears to a focal atrial tachycardia. This patient was in a narrow complex tachycardia. If we look, we do see the P wave is inverted. It's hard to know, on this EKG, if you're looking at it, by itself, is this, atypical AVRT, because it'll give you an inverted P wave. But we looked at telemetry, and it always started with a P wave with the same interval. So so we knew it was a low right atrial or focal tachycardia. So in patients who have an atrial tachycardia, the first question is, are they stable? If they're not stable, you can try adenosine. A lot of atrial tachycardias will terminate with adenosine. If that's not effective, you can proceed with cardioversion. If they are hemodynamically stable, once again, we're going to look at IV diltiazem, IV beta blocker, IV verapamil, as long as they have the blood pressure to support it. If those medications, are not effective, then your next step would be IV amiodarone or IV ibutaline. So, for ongoing, for patients who have an atrial tachycardia, it's a focal atrial ablation is an option. So that would be kind of the first option, the class 1 indication. If they are hesitant to pursue ablation, you're not able to pursue ablation at that time due to their clinical condition, then our medical, we're looking at medical drug options would be, beta blocker, calcium channel blockers, a class 1C if they have a structurally normal heart, or looking at amiodarone or sotalol, which would be a 2B. So, we do see patients with multifocal atrial tachycardia. I mean, these tend to be, patients with, a lot of times we'll see them in the MICU. They have underlying pulmonary disease. They have, metabolic or electrolyte abnormalities. They have an acute illness. With multifocal atrial tachycardia, you're looking at, typically you have 3 or more different P wave morphologies that are occurring at different rates. The treatment is, calcium channel blockers, beta blockers, treatment of the underlying, triggers if there's metabolic, electrolyte, or if they're having some type of pulmonary exacerbation. There really isn't a role for antiarrhythmics, cardioversion, or ablation, just because we're really looking at a multifocal tachycardia. Another SVT that we do see that can be much tougher to manage is inappropriate sinus tachycardia. These are patients who have a resting heart rate above 100 beats per minute. On an Holter monitor, they're going to typically have an average greater than 90 beats per minute. We're going to rule out secondary causes that could be triggering to make sure that this isn't a physiologic response. We're also going to rule out POTS or postural orthostatic tachycardia. An inappropriate sinus tach is really a diagnosis of exclusion. The treatment can be very difficult. We're looking at beta blockers, calcium channel blockers. The treatments, aren't the most effective. A lot of these patients, don't tolerate them either due to fatigue or blood pressure effects. I have a Bradine, which, has a heart failure indication. Its mechanism is that it does inhibit the funny channel that reduces the sinus node pacemaker activity. It doesn't have a blood pressure effect, so you can get slowing of the sinus node, and it has improved patients with inappropriate sinus tach. The hard part that I've had is it's harder to get it approved for sinus tachycardia. So, but it can be helpful in these patients with inappropriate sinus tach. So we kind of covered a lot. SVTs are common. If you look at all the SVTs, avrt is probably the most common across the board. If it's a regular SVT, I would recommend the modified Valsalva first. If that's not effective, adenosine would be your next step. The biggest thing with adenosine is just make sure you're ready with your flush, so that you infuse the adenosine. You've got a rapid push just to get give it the best chance. Hemodynamics really determine the next step if you need to proceed with cardioversion or with a medication. For the SVTs, if they're symptomatic, an EP study with an ablation is a class 1 indication, but it's a curative option. I mean, it basically, with a 3-hour procedure, we can cure these patients. And then, for patients who, are unable to proceed with ablation, we're looking at, at different medical management options. So we kind of covered a lot, kind of flew. I'd be happy to entertain any questions. And this is my contact information if you think of something afterwards.
Great. Thanks, Troy. That was a really nice talk. I'm watching the chat, and people can go ahead and put questions in there while we're taking the last few minutes until I see some questions pop up there. I'll pepper you with a few here. A lot of times patients will get first diagnosed with an SVT when they're in the hospital for some other reason. But as we know, a lot of times those telemetry records don't necessarily get preserved. What do you find most helpful if somebody has a patient with an SVT during a hospitalization and they want that patient to follow up with EP as an outpatient? What do you find the most helpful to be preserved in the tele record for you to look at?
I think the tachycardia and then the onset and the termination. I think we do have the ability now to cut and paste and copy into Epic, or we can print it off and then just. I've printed off telemetry strips that I wanted and just asked the unit clerk just to scan it into media, just so it doesn't get lost. But I think that would be the most helpful. Would be what the tachycardia looked like, and if we were able to capture kind of onset and termination, would be the most effective. A lot of times if we're seeing patients with the consult service, the fellows are pretty good about cutting and pasting a telemetry screenshot, into their notes, so we know what we're looking at.
Okay. And the other question I had for you was if you could tell a little bit about patients who already have an existing device like a pacemaker or an ICD in place. Can you talk about a little of how you might use that device to diagnose or treat an SVT?
So I think So I think one thing that we'll look at, I mean, with an ICD, unfortunately, some of these SVTs can get into into a zone where they could possibly, where the device is programmed to treat a VT event. So, some of our younger patients who have heart failure, they have rapid conduction. They can have an SVT that will unfortunately get into a zone where they may have therapy. They may receive ATP. They may receive an inappropriate ICD shock. On an ICD, if it gets into the zone, I'm going to look at what the device is programmed to give ATP or anti-tachycardia pacing, where it paces the ventricle slightly faster than the tachycardia rate in the hopes that it terminates. So, in some devices, for example, if they have a dual chamber device, they have a ventricular lead, they have an atrial event, so an atrial lead. So we're looking at the ventricular event, we're looking at the atrial event, and we actually can look at that snapshot. I'll look to see what the tachycardia did when the ATP occurred. So we know that functionally it's very similar to what we do in the lab when we have a tachycardia and we just pace faster and kind of, we're looking, did the tachycardia entrain? We're able to speed it up. Did we dissociate it? Did we pace the ventricle faster, but the atrial rate of the SVT continued uninterrupted? So, and then we'll look at the timing between the ventricular and atrial lead. A lot of times, if the V and the A are lined up, is it AV and RT? Is it, or could it still be atrial tach? But we're looking at more of a short RP. If they do have entrainment maneuvers, what did the A do when the ventricle was paced faster? Did we pace the ventricle faster, but the atrial, just continued on uninterrupted, which kind of confirms that we have an atrial tachycardia. So that's some of so I think it is easier on the ICD platforms just to kind of, because we if they get into a zone where they have an ICD therapy program, we can kind of look to see what the tachycardia did, with that ATP. On the pacemaker platforms, I mean, we can actually, we can look at VA timing. We can, on some of the devices, it'll give us the onset. We'll see that it started with a PAC, and it had a long PR, and then it started a short RP that would favor AV and RT. So a lot of it is, we're basically looking at what the device will show, and what it's recording in the respective chambers. So.
Okay, that's great. Thank you. So it looks like we've reached the end of our time here. Again, I'm going to turn the chat off, but Dr. Rhodes has kindly provided some contact information in case you think of some questions after the end of this chat. And I thank everybody for attending, and we'll see you next time. Thanks, Dr. Rhodes.
Thank you.